Well, good evening and welcome to the Wolper Wellbeing webinar hosted by Wolper Jewish Hospital and Friends of Wolper. And a special welcome because our topic tonight is cancer survivorship and life after cancer, a topic close to my heart because I'm a survivor of cancer myself. My name's Julie McCrossin, and it's my great pleasure to be your host for this panel discussion, which is all about the physical, mental and spiritual impact of cancer on the patient, on their families and their close friends, and the sort of support that's available to help us cope and manage and recover. And I'd like to begin by acknowledging we're broadcasting to you on the land of the Gadigal people. That's, of course, in the Sydney area. I'm with the Ghana people in Adelaide, and we may have people from other locations, but welcome to you all. And we acknowledge and pay our respects to elders past and present. Well, it gives me great pleasure now to welcome our panellists, and I'll ask our technical whiz Nat to bring them all on screen so we get to meet each other as we go. And I'll give you a full introduction to each of them as I come to them in discussion. But welcome to Professor Haryana Dhillon, a behavioural scientist and Professor of Psycho-Oncology. Welcome to Dr. Monica Tang, a medical oncologist from Prince of Wales Hospital, and she's a staff specialist in cancer survivorship. Welcome to Professor Nicolas Hart, an NHMRC research fellow on survivorship and a program director on clinical exercise physiology at the University of Technology, Sydney, and Dr. Michael Krasovitsky, who's a medical oncologist at St. Vincent's with a very special interest in geriatric oncology. So welcome to you all. It's lovely to see you. Can I come first of all to Dr. Monica Tang, if she could join me on screen? Welcome to you, Monica. And I'll just say again, medical oncologist, staff specialist, cancer survivorship, and is at the Nelune Comprehensive Cancer Centre at Prince of Wales.
That's right. That's where I work, both as a medical oncologist and also a specialist in cancer survivorship.
And you lead the Cancer Survivorship Service and run a weekly cancer survivorship multidisciplinary team meeting. You know, this notion of cancer survivorship, I don't think it's well known. We haven't got as many people as normal tonight, and I'm urging us all, everybody viewing, that we'll send you the link, and you can also have it on the website once it's recorded. And let's share it widely because this is such an important topic. But I thought perhaps the best way to introduce people to what this is all about is for you to talk about your service. What does it offer people, and who's eligible to get this cancer survivorship support?
Yeah, so thank you, Julie, for that introduction. You're right, it's not the cancer survivorship, I don't think is commonly well understood in the general community. And sometimes even amongst my colleagues, amongst clinicians, I think it's a relatively young field clinically and also in terms of research, which I think makes it a really exciting space to be in, both in terms of providing the service to patients and also trying to advance the field. So at Prince of Wales Hospital, we established the cancer survivorship program about 3 years ago. And it's because we've recognised that a lot of patients, even after they've finished initial treatment for cancer, whether that be surgery, chemotherapy, radiotherapy, targeted treatments, often still had residual side effects from cancer and its treatment. And sometimes they're physical side effects like fatigue or neuropathy, which is nerve damage that can arise from chemotherapy. And a lot of times it was also what I call emotional side effects. Patients will report feeling more worried or anxious, or there's a phenomenon that's well described in research called fear of cancer recurrence, which I think affects such a large proportion of patients to some degree. And so I work with a team consisting of myself, exercise physiologist, a dietitian and a psychologist, and we have tremendous support from the rest of the hospital as well, from the physiotherapy department, occupational therapy, because I find that, you know, once patients come to the end of their medical treatment, I always say you've probably had enough of doctors and maybe nurses as well, and what they really need is, you know, supportive care from those allied health specialties, from trying to improve their, physical activity levels. A lot of patients are really motivated to try and improve their diet to get themselves healthier and maybe prevent cancer recurrence. And a lot of people do need a lot of psychological support to try and get them back on track so that they can have really good quality of life, because as a medical oncologist, we have been focused for so many decades on curing cancer, on giving people the extra years. And now I think it's really important to also make sure that those are good quality years, that they have quality as well as quantity.
And would it be right to say that the sort of cancer that you have will be a key predictor in terms of how long you may have lasting side effects? I'm a head and neck cancer survivor, throat cancer, and in my cohort of peers, it can go on for many years and even for lifelong. But I think in other sorts of cancers, you can more optimistically hope that the long-term impacts, at least the physical ones, will be reduced. So can you give us some sense of how varied the survivorship needs may be depending on the type of cancer?
Yeah, absolutely. I'm really glad you brought that up, because I think one of the things that we also wrestle a little bit with as clinicians and patients and researchers is what a survivor is, and it's brought in its broadest sense, cancer survivor is anyone who's ever been diagnosed with a cancer from date of diagnosis through the balance of their life, and so that includes patients who have been diagnosed with early cancer, recurrent cancer, advanced cancer. Now, not that term may not resonate with everybody, but it is a very inclusive term. And because it's such an inclusive and such a broad term, you're right, it's a diverse population of patients. And I think certainly the type of cancer will influence what a person's survivorship journey might look like. Someone with very early stage, for example, breast cancer, who just needs surgery, will have a very different experience to someone who might need someone with relatively advanced bowel cancer, who might need multimodal treatment with surgery, radiotherapy, chemotherapy. But I think there are other predictors of someone's survivorship experience outside of the type of cancer and the type of treatment. I find that a lot of times it's a person's comorbidities, what other health conditions they bring to their experience, their age, their level of social support. Also, unfortunately, sometimes, their health literacy and their, physical resources will also determine how much support they have and how, they're best able to care for themselves. So there's a lot of different factors.
One more question I wanted to ask you was, there is mainstream follow-up for some patients, some types of cancer patients, and it's unclear to me how like, so if I'm sorry, I'm drawing on my own experience just because it's a natural thing, but when you're a head and neck cancer patient, particularly in the first 2 or 3 years, I was called back to the hospital just by my mainstream cancer team, lots, because that was the most acute likelihood period of recurrence. But my understanding is other types of cancer, you would not have that frequency of callback. So I'm trying to get what's the relationship between mainstream multidisciplinary team follow-up and then going to a specialist survivorship service, because you're even in a separate building on the campus. You are clearly a separate specialist service. So can you just give us a bit of help in that?
Yeah, so you're right. At Prince of Wales, we're very lucky to have a separate building. It's a old sandstone cottage that's been refurbished as a survivorship centre, and inside it looks nothing like a hospital. It looks like someone's very, very tastefully decorated house, and patients always like being in a different setting. But I guess going back to your question, Julie, about the difference, and it's something I've actually really reflected on over the past few years, because I've been working as a medical oncologist, treating breast cancer, giving chemotherapy, following up patients, whilst practicing as a specialist in cancer survivorship. And the way I describe it to patients is that in routine oncology follow-up, I feel like doctors dictate the agenda a lot of the times. We've given you treatment, we think we've cured you, and it is our role to make sure the cancer hasn't come back, to try and minimize the medical side effects of treatment. And I certainly run through a list of questions every time. Have you got these symptoms? Have you got these symptoms? This is your next scan. This is your next blood test. I'll see you in initially maybe every 3 months, 6 months, 12 months later. And often the appointments in terms of resourcing tend to be they're quite brief, maybe 15, 20 minutes, half an hour if you're lucky. In my survivorship service, I see patients from all sorts of backgrounds, and I trust that their oncology team have given them the best possible care from a medical point of view. And I actually say to patients, look, you're a survivor, but every survivor is different. What are the main issues that bother you? What can I do to help them? And so I let them set the agenda, and whether it's fatigue, neuropathy, fear of cancer recurrence, depression, wanting to eat better and move better, I let them lead the discussion, and I have a whole hour to talk about that with them. And so I think even though I'm the same person with the same skill set, when I'm in different settings, I sort of tell patients, this is the expectation for this setting. I'm not, and patients will ask me to organize scans or do blood tests or medical questions. I say, look, that should be driven by your oncologist. Let's talk about the non-medical things that are actually influencing your day-to-day function and quality of life.
Thank you so much, Dr. Tang, and we'll come back for more, but can I just say, hearing the word an hour, I already know this is a very different kind of engagement with the patient. It's almost a luxury thing. But just before I let you go, it's only patients from Prince of Wales that can access your specialist survivorship service at this stage, isn't it?
That's right. At this stage, it's for patients who've received treatment at Prince of Wales Hospital or the Royal Hospital for Women next door, which is co-located with us.
Look, thank you. I'd like to welcome now Professor Haryana Dhillon. Haryana is a professor of Psycho-Oncology at the University of Sydney. She's a behavioural scientist and the chair of the Psycho-Oncology Cooperative Research Group, but also co-lead of the Cancer Survivorship Research Group. So welcome. I'll just give you some deaf sign clapping to welcome you. This is deaf sign clapping, and it's just a movement that I love. We've just heard that the area of survivorship is about a whole range of things, not just the medical care. When you're explaining what the field of survivorship is about, how do you describe it? And why is it receiving so much more attention, both clinically and in research now, Harry?
Thanks for the great question, Julie, and thank you for having me. I think cancer survivorship is something that's been, relatively new. As Monica said, we've really been focused very much just on treatment and getting people to live longer. And as our treatments have improved and people are living longer with cancer after a diagnosis, whether that's with no disease or a long time with advanced disease, then the emphasis has become much more on the whole holistic experience of the individual. So we want people to live longer, but we want that to be good quality of life. And I think that's really why this issue of cancer survivorship has emerged, or this area of practice and research, because our current medical systems, and there have been many reviews and reports that have highlighted the way that standard medical care is not able, cancer care is not actually delivering supportive care in the way that actually addresses the symptoms and the needs of people.
And my understanding is Australia has among the highest survival rates in the world. And as we've got better and better at keeping us alive, there's actually more need now because there's more people alive for longer. So that's just a practical, positive element in this, isn't it?
Yeah, absolutely. We do have fantastic survival rates, compared to many other countries. And we've also always had a very active supportive care practice in terms of palliative care and also in research in those areas. So we've been very consistently leading in that space globally as well. And I think that's one of the other reasons this has become very rapidly an area of practice in Australia, because we have got a lot of research which backs the way that we might treat the symptoms and support people better.
And I'll just let our audience know we will be talking too about people living with metastatic cancer and also focusing particularly on what's called geriatric oncology. Because I'm 70, I don't like the word geriatric. I'll call it older people oncology, but I'm just letting you know that's coming. But Harry, one of your key messages is that the psychological impact on people, that's both the person with cancer and those who love them, is immense. But we do have a toolkit of things to help the person, but don't wait till you're at crisis point. Can you give us a sense of what that toolkit is?
Mm-hmm. Sure. So, I think it's different at different stages of the, as you move through treatment and into survivorship. And I guess one of the things that I would say, and I think Monica's approach really highlights this, is that spending time talking to someone about what are the things that really bother them is critically important. So I don't know unless I ask people what their concerns are. And I think there are many times when people suffer or experience symptoms that they don't talk about because they don't know that they're important or that anybody can do something about them or help them. And I think, this idea of the new normal is something that really is not static. So it's like anything else that you go through a change in life, and things can change for the better or worse, and we can still continue to do things to help with that. And so in terms of the psychological aspects of cancer survivorship support, I think it's really important to recognise, as Monica said, that being concerned about the cancer coming back is common. And that's a really almost universal concern that people have, and for justifiable reasons. And so we do have evidence-based interventions that are psychological interventions that help people learn to live with that uncertainty and the concerns and the fears without it intruding on other aspects of their lives. So there is an intervention called Conquer Fear, which is available, and we know that actually helps people reduce their fear of cancer recurrence. But I guess just in terms of other aspects, I think, there are different strategies that people will be able to teach you or give you. So things like mindfulness, meditation, stress reduction, cognitive behavior therapy, which can help people with many symptoms to help you sleep better, to manage depression or anxiety. All of those sorts of things can be really helpful. And there are these tools that you can use, and it may be something that you don't need to think about or practice all of the time, but when you start to feel things changing or you're feeling those distress levels increasing, then you've got the tools to apply to help you reduce that before it becomes more problematic. And I guess we have this image of psychological and psychiatric support to be there when things are really bad. And my key message would be, we want to help you develop those skills and know how to apply them before you get to that point, because maybe we don't need for people to be reaching crisis point in order to use those skills and to reduce the impact on themselves and their family and the wider community as well.
My observation as a cancer survivor, I was treated in 2013, is some people gain enormous comfort and support from peer support. So a group, whether it's organised with a professional or a self-help gathering, whether it's face-to-face or online, to meet other people who've had similar cancers can really help them. And then also I know other people who don't want to do that. And so I just wondered, what is there research to indicate what proportion of people could get comfort and survivorship support from peer support?
That's a really good question, and I don't know the answer to that, Julie. I think that it is very individual, and it's different for people at different times as well. So some people may want to engage with connecting with their peers during treatment, particularly if they're able to connect with people who've been through the same kinds of treatment to sort of, I guess, give you some hope that actually these, you can get through these challenging treatments. And many other people really just don't want to engage with other people, and I think there's certainly evidence to suggest that support groups and peer support facilitated by people who are trained is more effective than than just kind of connecting with somebody who has had a similar experience. I think that sort of structure around making sure that the support is well directed and well managed is really important.
Thanks, Harry. And I'll just mention that I know Cancer Council New South Wales, and it may be other cancer councils, do run online forums that are moderated I've joined the head and neck one, for example, at times, and people are sharing and supporting each other. There's not a professional present, but you know it's moderated. So I guess that's a partial safety net. Look, I have to get one last comment before I bring in Professor Nicolas Hart, the exercise man and so much more. But exercise is critical. You've all told me that in my prior conversations. And I know, Haryana, Dhillon, you've played a role in some research that's come out called the Challenge Trial. Could you just, in a nutshell, explain the lessons from that, published in the New England Journal of Medicine, which is like the Emmys of cancer or Emmys of health, and its relationship to our topic tonight of cancer survivorship?
Yeah, so the challenge trial was has been the first randomized trial in a cancer survivorship population to demonstrate an overall survival advantage to people who engaged in a structured exercise program. In our study, that program lasted for 3 years. So people had the support of an exercise specialist, and in the study, most of them were accredited exercise physiologists who had experience working with people with cancer. The intervention started off fairly intensive. So the participants in the study came to the program, saw their exercise physiologist at least fortnightly for supervised exercise, and also had a behavioural counselling session to help overcome the barriers to exercise that people commonly experience, and that could be, me, Monica, any of the other panelists, and all of you listening, that it's hard to fit in exercise and it's hard to maintain that motivation, and that's what the exercise physiologists really help them do. Once the exercise was embedded after about 6 months, we started to taper off those support sessions so that it became less frequent. And often, if things were going well, it was done by telephone call or email check-in or video conference. But I think that accountability to someone, knowing that someone was going to be checking up on you, but also there to support you overcoming the barriers, was really critically important. So we know that the exercise program helped people live longer. They had people in the program also had fewer colon cancer recurrences, and we saw fewer new primary cancers, both including colon cancers, breast and prostate cancers. So I think there's some really important work that we're continuing that will help us to understand the mechanisms by which exercise helps to reduce the incidence of cancer, both colon cancers, but also other new primaries, as that data is analysed. So we have biomarkers that are on ice at the moment that are soon to be analysed that will actually help us understand those mechanisms.
So this is, in a nutshell, extremely powerful new evidence for the value of exercise and its relationship to cancer survivorship.
I think it just is generally a really strong indicator that exercise can help people recover, can help them reduce their mortality from other causes, but also from cancer-specific causes. And I think there was one thing else I was going to say, which has just popped out of my head. If it comes back to me, I'll let you know.
Well, I'll be coming back, and just to let our listeners and viewers know that Professor Nicolas Hart will be talking about survivorship with a big emphasis on the importance of exercise physiology and other issues. And also Dr. Michael Krasovitsky will be joining us as well. But just before I do that, I think we should go to hear from Dr. Carmela Milka a couple of questions from our audience. And then, gentlemen, I'll be coming straight back. So welcome to our general practitioner who's moderating the questions and has received questions in advance. Over to you, Carmela.
Thank you. Julia, we've had quite a few good questions. I'm going to give one that was sent in before, and it said, what are some tools or suggested dialogue that can be used to start conversation with those who don't know how to talk about it?
That's very interesting. Look, I might come to Dr. Michael Krasovitsky, if I may, and I'll just reintroduce you. Michael is a medical oncologist at St Vincent's Hospital in Sydney, and he specialises in geriatric oncology, so older people oncology, with a very primary focus on optimal, the very best care for people with cancer. How would you answer that? How do you initiate conversations with people who are in their survivorship period and you're wanting them to talk to them about what they need to do to help themselves?
Thank you, Julie. That's an amazing question, and thank you to whoever submitted it. May I just say one tiny thing before I attempt to answer that question? I do really want to highlight and congratulate my colleague, Haryana Dhillon, on the challenge study. I haven't had a chance to call you yet, Harry, but that is a real game changer in our field. It really puts emphasis on how important exercise is, not only for increasing our own self-worth and our own agency and our own power, but also from a medical perspective, we know inherently that exercise makes you live longer, feel better, and live better. And I just really want to congratulate Professor Dhillon for that. It's a really amazing feat from an Australian team. Now, how to answer the question, the wonderful question.
Yes.
I think the main message about cancer survivorship is, well, there's I guess a couple of things that I would say to a friend who is in this process. The first one of which is that we all deserve to lead robust, full, fascinating, engaging, healthy lives. And though cancer can attempt to strip that away from us and make us a diagnosis and give us a compartment with which to live, it is in fact not powerful enough to push us into the shadows. And we have to come after a cancer diagnosis and through the treatment of cancer to a state where we can live as good a life as we possibly can. And so to a friend who is beginning this journey, I would say, yes, I am not denying that cancer is a really important part of your life, and I want to be on this journey with you the whole way. But let's also forget that that's just one part of your life, and you deserve the best possible life you can have. How are we going to establish that together, and how are we going to work towards it?
Can I just come in, Michael, because you're positioning yourself as a friend, whereas I think this question is coming from someone who maybe either themselves or someone they know want to encourage them to ask for help, to seek help in a multidisciplinary sense, and they'll have to open up in some way emotionally about the needs that they may have, and they may need help to do that. That's how I interpret that question. So as a doctor, so you've got someone and you think, this person, I've got a team of people here who might be able to help them, but they are saying, I don't even want to talk about it, or I've had enough of hospitals, doctor, I've had enough.
So I would have a few comments to say about that. So the first thing is, I do feel that primarily this is in fact the purview of the medical team with whom the patient, has the most interaction. It is our responsibility to ensure that individuals receive survivorship care, in the same way that it is our responsibility to ensure that they receive the right chemotherapy and the right radiation dosing. It is our responsibility to ensure that our patients experience good survivorship care. And we all do it to a certain extent. We do all talk about fatigue and we all talk about neuropathy. But I think one of the key messages of this session is to say that that's really not enough, and that specialist survivorship services and a specialist team looking at optimizing life for people with cancer or who have gone through treatment for cancer is really critical. And so it's really up to the doctors and the nurses to ensure that that is put in place. If it's not, let's remember that, and I say this to my patients all the time, you're the boss. You're in charge. You are the boss. I am here to support you on whatever journey you're on, as is your general practitioner, who is the cornerstone of really any long-term survivorship program. And I would encourage everyone attending, if they feel that their survivorship needs aren't being met, whether that's fatigue, something you may have experienced, Julie, which is dry mouth, trouble swallowing, neuropathy, sexual dysfunction, intimacy problems, feel empowered to say something to your team. And it can be any member of the team. It can be a nurse. To be honest, it might even be the administrative staff with whom lots of our patients develop good relationships, but feel empowered to say something because we all really want to help.
Could I ask Dr. Monica Tang to join Dr. Krasovitsky on the screen? Because I just want to ask a question before we move on to our next question. And it's this. What is still haunting me, Monica, is where you said you had an hour, and you've got a specialist service. Now, as I understand it, they're pretty rare in Australia at the moment. This really is an emerging field. And as I listen to you, Michael, while all of that is true, what you've just said, in my experience as a patient, and correct me if I'm wrong, most of us don't get more than about 10 to 15 minutes with a doctor. You've got to be in terribly bad trouble and you'll be referred out. But there's also something called 5-year survival. And again, if I could ask each of you to reflect on the significance of that. But my experience of it with myself, and I've heard it from others, is that at 5 years, you've made it. There's some sort of line that's drawn and you're farewelled. You are now utterly with the general practitioner and you don't have access to the speech pathologist, the psycho-oncologist. You don't have that access to the hospital team. I felt like I was leaving the mothership and I found it quite disturbing, to be honest with you. And I don't think I'm alone. So I guess I'm I'll get a comment from each of you. I'll start with Monica, if I may. Is part of what we need to be doing advocating for more specific survivorship services or more time for mainstream teams to provide survivorship? Your thoughts, Monica, and then I'll come to Michael.
Yeah, look, I think it's a really interesting and a really big question, which is essentially what's the best way to deliver survivorship services to the Australian population. I think at Prince of Wales Hospital and at a lot of metropolitan hospitals in Sydney, such as Concord Hospital, they've had a survivorship program for more than a decade. We're lucky enough to have that concentration of specialists in different allied health fields and for the leadership for those teams to be created. But I don't think that would be necessarily feasible all across Australia, especially in the more rural and remote areas. And I think, so I work with the COSA Clinical Oncology Society of Australia survivorship group, and we're part of the models of care implementation policy working group. And one of the questions we tussle with is how can we scale up something like this so that everyone can access it? And I think part of it is certainly to have, these kinds of services aligned with cancer centres and cancer clinics so that they're easily accessible. Cancer clinicians like Michael and myself can easily refer patients to them and patients know where to access them. But I think that certainly, as Michael said, general practitioners, I think, play a really important role. And I think in terms of that 5-year mark, that's such a great question. I think sometimes it's almost an arbitrary line that we draw in the sand because not every cancer behaves in the same way. A lot of cancers, if they will recur within 5 years. But Michael and I both treat breast cancers, and we know that there's no magic, nothing magical happens at the 5-year mark that says you're cancer free after that. And often we will follow patients up long after. And at the experience that you had, Julie, is not uncommon that patients say that there's some comfort. Sometimes it helps with their fear of cancer recurrence to come back to the same centre to be given the all clear by their oncologist. And so I think one of the solutions is not to wait until you've crossed the 5-year mark to access survivorship services. The need for exercise, diet, psychology input, that can start from even while you're still having treatment or maybe soon after you've started treatment. And interestingly, when I started the survivorship service at Prince of Wales Hospital, a lot of the referrals I got were from oncologists who tried to discharge their patients after 5 years, and the patients balked and said, "Oh, you can't let go of me. I need someone to help me." And so they were referred to the survivorship service where I could provide a bit more sort of multidisciplinary support. But now more and more I'm actually getting patients earlier in the survivorship journey because we know it's not just sort of survivorship starts after you've passed the 5-year mark. I think survivorship actually starts a lot earlier than that. And I'm really, really pleased to see that there's been some sort of change in practice and understanding of where survivorship fits in with the rest of their cancer care and follow-up.
Just before I come to you, Mike, if I could just offer a comment as a patient, I think I think I can speak for more than myself by saying we develop a very close relationship with key clinicians in the multidisciplinary team. There's something special about cancer, I think, in terms of the level of, perhaps it's because of the ever-present possibility of death. It is, anyway, I won't, it's not my place to reflect. But I do think there is a sense of trust and connection, often with the doctor and often with others, so that we don't want to lose you. It's not just a service, it's a relationship that's seen us through an existential threat. And so I meant that idea of developing connections with multidisciplinary supports prior to the 5-year mark could help us. They're new clinical relationships that might help us make that transition, because in the end, it's all about rationing. It's an arbitrary point that's based on data and it's rationing. But Michael, just a comment from you on that, whether we need more specialist services or just more education and staff to do survivorship within our mainstream cancer services.
Thanks, Julie. And I know I'm being a big fan of all of my colleagues tonight, but I do just want to shout out that Monica has done an incredible job at Prince of Wales and, is really leading the way in that space. So my comment is ideally best of both worlds. There is a program and a clinical pathway that was developed by Haryana called the ADAPT pathway about anxiety and depression in people with cancer. And one of the key messages that I took away from that program is that there are lots of individuals with cancer, and I'm using this as an analogy for survivorship generally, who have low survivorship needs or moderate survivorship needs. And then there's that group of people who have very high survivorship needs, pervasive fatigue impacting on their quality of life, neuropathy, significant bowel dysfunction. And though providing expert survivorship care for all patients would be the ideal, that is probably not practical in the Australian context and given the funding constraints that we have. And perhaps what we should be doing is actually working really closely with GPs and providers outside the hospital system, physiotherapists, exercise physiologists, Wolper Hospital, to create a community of people who are engaged in physiotherapy and exercise for people with cancer. And I know Wolper's very good with that, and there's excellent exercise physiology in that space, but perhaps what we should be doing is a specialist looking after those really, really complex individuals and then getting the community to support us with individuals who have perhaps lower survivorship needs, though very valid survivorship needs.
Look, I'd like to welcome onto the screen, and I'd like to keep Monica Tang and Michael Krasovitsky, but could I welcome Professor Nicolas Hart? And Nicolas, I want to bring you in, and I'm sorry I haven't already. Nicolas is the NHMRC Research Fellow. He is an NHMRC Research Fellow on survivorship, the chair of survivorship group in the Clinical Oncology Society of Australia, and the program director of clinical exercise physiology at the University of Technology, Sydney. Now, I know there's so much on survivorship, but one of the areas I know you have a great interest in is access and equity, the role of the general practitioner, but also patient navigation. So I wonder if I could bring you in on this issue of your vision of going forward so that all people who've had cancer treatment, whether it be can access multidisciplinary support when they need it after that acute period of treatment. Your thoughts of a vision, I guess, Nicolas?
Yeah, so you're right in saying to access it when they need it, but also where they need it as well. Because as you say, there are people that live in rural and regional Australia and in other areas that might access specialist care in the city urban centres and then go back home, for example. And you're so right. So I think listening to the conversation that others were saying around having a community of practice, so to speak, and greater engagement with the general practitioner is so fundamental, I think. And so there's quite a lot of research at the moment, being led largely by Australia, which is wonderful, in the development of models of care and how we can have models of care that sort of share the follow-up of the survivorship of the person affected by cancer in the survivorship space between the specialists, so people like Michael and Monica, and a nominated GP to be able to provide that sort of shared care arrangement, because general practitioners would define themselves as specialists in chronic disease management. And so whilst the oncologist and the hematologist might be treating the tumour, general practitioners are very good at managing issues of polypharmacy, where you might be taking a range of different medications for a range of different conditions. They also are I don't want to say the gatekeepers, but the custodians of being able to provide a GP management plan or a chronic disease management plan, which is kind of like a connection to your allied health services in community. Because as you say, specialist cancer survivorship services, I can only think of probably 4 or 5 in the entire country, and they have all largely been founded through philanthropy and maintained through philanthropy, mind you. And I think that is an indictment on maybe our government to recognise that survivorship being funded by the people affected by cancer, which includes the person with cancer and their caregiver and family network, says something about the identified need of those people versus maybe what the government thinks is valuable in these circumstances. And so to move on to your question about patient navigation, it's definitely an emerging area that is, it's obviously been around for some time, but having the dedicated workforce to provide effective patient navigation is something that's starting to evolve. So last year, or the year before, the federal government put in an historic landmark amount of investment into what's called the Australian Cancer Nurse Navigation Program, which is currently being trialled in Australia at the moment to try and provide a cancer navigation workforce, in this case using nurses, but you could use a range of different health professionals and non-clinical workers to provide this service.
And what exactly would they do?
Yeah, so the premise is that they help reduce barriers of access to care. So obviously people, Monica said it at the beginning about people's health literacy has an influence about what they access, where they access, and what they think they might need. And a patient navigator really helps connect them with the services that they might need. So for example, a patient navigator might be involved from the point of diagnosis to help access quick diagnostics, quick referral to treatment, and so on and so forth. But then they might also be involved with connecting a particular person affected by cancer to exercise physiology or to particular services, because one of the challenges is knowing what services are even out there to begin with.
You know, I just want to come back to this issue of time and relationship, because I'm very aware that over half our audience are over 75, and therefore, like me, they've probably got a care plan. I've got a chronic disease care plan. I've got diabetes. And what happens is, and I think it's a fantastic system, and I think it's helping me see my accredited exercise physiologist, which I know you all agree with. But what happens is I actually have a relatively brief time with my general practitioner, and I have a longer time with my nurse. And so I guess I'm just thinking that in terms of expertise, I'm wondering about the employment, for example, of more nurses with cancer expertise, because, yes, it's just that I understand just time matters in developing relationships. Let me give us an example. Who was it who said we deserve to have a sexual life? Was that you, Nicolas? No, it was Michael. Can I come to Michael? Now, Michael, who you'll remember is the a medical oncologist specialising in dealing with older people or geriatrics. And you had a number of messages, that if you've got fatigue, let people know that you can get help with structured exercise, aggressive sleep management. If there's time, I have to ask you what aggressive sleep management is like. A dietary guidance with a protein focus. So you've got lots of things, but you also said everybody deserves a good sex life. Now, the impact of cancer treatment on one's intimate life, I don't even like sexual dysfunction, to be honest, just because it does sound like, anyway, I think we need gentler words if we're going to get people to speak. But don't you think you need time to get someone to open up about their sexual life? Or under this model, would you be referred to someone that Professor Haryana Dhillon, the Psycho-Oncology group, would recommend? Just look at this time issue when it's intimate. Your thoughts, Michael?
I'd be really interested in Monica's thoughts on this as well, but no, not really. I mean, I have the great pleasure of looking after women with breast cancer. Normalising vaginal symptoms is an enormous part of my job, explaining to people that almost everyone develops vaginal dryness, abnormal secretions, they can have difficulty with sex, putting it in really non-judgmental terms and just making sure everyone realises it's normal, in and of itself is a destigmatising approach. There is no stigma around cancer affecting your sex life. It is an extremely normal part of the process and the journey. And I think saying that really openly to people, breaking down the discomfort quite quickly and quite easily, does actually lead to a very meaningful conversation for a lot of people about how to optimise their sex life. Because
can I bring Professor Haryana Dhillon onto the screen as well, if we can make all these squares work? And I promise, Carmela, I'm coming back to questions in a moment, and we'll do some with rapid fire. But help me, Harry. I think there's some research that indicates that the vast majority of doctors are uncomfortable raising sexual issues with their patients. I could tell Michael anything. I can tell that already, but I'm wondering how representative Michael is.
Yeah, and I think that's a really good point, Julie. I think there are many health professionals, so I'm not just doctors, but many people who are very uncomfortable talking about sex, and I think that really impacts because they're signalling that they're not comfortable and that they don't want to talk about these things. And so we were running a study a few years ago now, which was designed to address sexual communication between couples. And one of the things that the clinicians who were referring patients to that study really liked is that when someone raised concerns about their intimacy, they could give them a postcard and go and look at this study in this website, and that will help you, and didn't have to talk about it anymore. So I think there's a huge variation between this. But I think just to sort of follow up on Michael's point, if you can be open about it, and it's not about disclosing what you know, anything about yourself necessarily as a health professional, but it's about recognizing that sex is a fundamental part of people's lives. We ask about you know, vaginal dryness or bowel motions and things like that, and so it should not be any different to that. And I think that would kind of be my key message for health professionals, but I guess from an individual cancer survivor or carer perspective, one of the things that happens is that lots of people don't really talk about their sex life when it's going well. And so then they're confronted with these changes and they don't have a language in their relationship to help them have those conversations. So the fact that, you know, a health professional can talk to them about this and raise it, it may actually just be the trigger for people to say, oh, I do need to think about and talk about this with my partner, or, you know, or with other people to try and come to terms with it or address it or work out strategies to cope with it.
If I could just add one thing quickly, Julie, on that as well, I think it's just, I agree with everything that Harry has just said. And I think one of the things as well is to not make assumptions about the cancer survivor that you are engaging with. So a lot of the work I do is with men with prostate cancer. And so typically speaking, they are of an older age. And sometimes there's this pervasive assumption that men of an older age are not interested in sex, which actually, when they did a survey of unmet needs of men with prostate cancer or people with prostate cancer, sexual health was one of the top, if not the top, unmet need. And so it's making sure we don't allow our own stigma and our own biases and our own thoughts and experiences to be projected upon the potential cancer survivor as well. And as Michael and Harry and Monica have said, is create a very welcoming and non-judgmental space to be able to have those conversations.
If I could ask for a quick comment from you, Monica, and then I will go to questions. But I just wanted to say, in this area, I have heard it said that in the cancer survival world currently, there's been a predominant focus on physical function and less on the psychological sensitivities. And I'm just wondering, in terms of, I think you've worked with women with breast cancer, and in your current role, you would at Prince of Wales, you know, if you have had surgery to your breasts, you may not feel attractive anymore. It's not about a functional dysfunction. It's about how you feel about dating and kissing. In the head and neck area, a lot of people have trouble kissing because things have happened to their mouth, or they dribble. So they just don't feel attractive. So your thoughts on this sexual side before we go to general questions?
Yeah, look, I agree with everything that Michael, Harry, and Nick have mentioned, that I think it's about trying to normalize asking about it. You know, I always try to include it in my list of questions. And if the doctor can talk about it without embarrassment, that often sets the tone for the patients, and they'll really open up about it. And if I find that if you start with a sort of physical question, vaginal dryness, things like that, patients will often actually open up about their relationships and intimacy challenges. And like you said, Julie, a lot of patients, and a lot of them are women, they will talk about, changes to their appearance and their confidence and their body image. And so on the theme of, there is help out there, we did for a while have a reproductive psychologist working as part of our survivorship team. And contrary to what you might assume with her title, it wasn't just about talking about fertility and things, but also about relationships and intimacy and body image and menopausal symptoms and that whole gamut of symptoms and challenges that can come with cancer diagnoses and treatment. And she often talked with patients through a lot of their issues. And, sometimes there might be interpersonal challenges, how to communicate with your partner, how to, establish other ways of connection, and also just normalizing the experience, because as you say, a lot of patients, they may not talk about it because they think, well, I've got 10 minutes with my oncologist. I really want to know that my cancer hasn't come back. I'm not going to use the time to ask about sexual function. And I think that, then that sort of puts the onus on us as health professionals, if we do have the time and resources, to say, hey, if that's important to you, that's important to me, and these are the things that we can do to try and support you.
Thank you for that comment, because when you are lucky enough to have survived, you sort of think, hey, doc, I'm having some trouble kissing. Unless they actually actively encourage you, you're unlikely to raise it. Now, listen, I want you to help me to be disciplined now. I want Dr. Camilla Milker, our general practitioner, to give us another question, and we'll try to get through a few questions in an efficient way. Thank you, Camilla.
Thanks, Julie. I'm actually going to, it's a bit of an umbrella because there's been a few around it, and then I'm just going to give 3 related to it. So a lot of questions have come through regarding exercise. So the one is, it said, I've heard that you should exercise immediately or even the same day following chemotherapy to increase its effectiveness and minimize side effects. Is that true? So that's on the day of chemo. Then somebody else also asked to hear about exercise and its role in chemotherapy. And then another question was just exercise in survival. So topic of exercise, and if we can just maybe
key points.
Focus on those. Thank you.
Thank you so much. And before I come to our medical oncologist and also Nicolas Hart, Haryana spoke earlier about the challenge trial and the amazing evidence published in the New England Journal of Medicine indicating the incredible capacity of exercise to help us live longer, in a nutshell. And I think you wanted to mention, Harry, did it give guidance on how much exercise and timing? And then I'll come to the other questions.
Yeah. So I guess one of the things that I wanted to just kind of point out was that we weren't trying to turn people into, marathon runners. It was really taking a group of people who were not meeting the current guidelines for exercise for adults in Australia, which is 150 minutes of moderate physical activity a week, and then at least achieving that and maybe doing a bit more. So I think that was really what we focused on, was that kind of aerobic exercise. So
and just explaining aerobic.
So walking, so cardiovascular fitness, walking, swimming, running, biking, those kinds of things. Most of the people in our study engaged in walking. And so they were walking really probably for 30 to 40 minutes, 4 to 5 times a week. And that was kind of the target for what we were engaged in. So, one of the things that I often say jokingly to people is get a dog because that gets you out walking.
Yes, we'll come to dogs before the end of this session because we have some dogs with us tonight. Dr. Tang, the questions around when you start exercising and the links to chemotherapy.
Yeah, so I think there's a lot of emerging evidence that exercise during chemotherapy is beneficial in so many ways. I think maybe conventional wisdom has it that chemotherapy will tire you out and you'll be tired, you've got to rest up and take it easy. And that's exactly the opposite of what I tell my patients now. I tell them that people who exercise during chemotherapy have less side effects, they have less treatment delays, they have less dose reductions. And I guess one of the more exciting things is that there's some evidence that it helps chemotherapy to work better. So one of the ways that we give chemotherapy for some cancers is that we give chemotherapy upfront for maybe 3 to 6 months, and then we do surgery to cut the cancer out. And one of the things we like to look at after surgery is how much of the cancer has responded to the chemotherapy, whether 50% of the cancer cells have died, whether 90%, or, you know, in the best case scenario, or whether the cancer's melted away completely. And there has been good research to show that patients who exercise during chemotherapy and then go on to have surgery, they have a higher, what we call a pathological response rate. So there's a higher chance that their cancer will actually melt away. And I think that's one of the best pieces of evidence we have, that, you know, chemotherapy and exercise really are synergistic. So I tell my patients without fail, I want them to move when they're having chemotherapy, and I don't need them to be doing the 150 minutes a week that we'd like them to aim for after treatment. But I say, I'd like you to go for a walk every day. If you can manage 20 minutes around the block, that's great. If you're feeling terrible and it's only 5 minutes to the letterbox, you know, that's okay as well, because I treat patients from the ages of, you know, 30 to 85. And there are some patients who are keen and they manage to go to the gym a few times a week, and that's fabulous. But, you know, moving enough to help the chemotherapy work to reduce the side effects, that's the goal.
Fantastic. Nicolas, Hart.
Yes, I'm more than happy to provide comment on this. And so everything Monica has said is 100% spot on. So with the question asking around whether they should exercise on the day of or after chemotherapy, absolutely, but they should obviously be exercising leading up to chemotherapy as well as, of course, after, because what the evidence shows is that exercise is able to help the chemotherapy circulate better. And with regards to tumour biology, it's actually able to help the chemotherapy be more better delivered to the area that it's needed to be to impact change at the tumour level. And I think one of the other exciting things that's happening in this space with emerging evidence is that we're starting to see the same effect with radiation therapy as well. So that tumour cell death following radiation therapy is more stabilised in the presence of oxygenated blood, which is delivered to that area through exercise. And so what I try to tell people is that exercise is many different types of medicine. So for example, if you get radiation or chemotherapy, it can damage your heart, your lungs, your muscle, your bone. And so where Haryana was talking about before about aerobic exercise, walking, brisk walking, or swimming or running if you can, that does a lot to help your heart and lungs. But of course, particularly in the population that Michael would see in the geriatric oncology space, low muscle mass and low bone mass is another issue that needs to be addressed. And that's typically addressed through what we call resistance training or strength training. And I just wanted to reiterate something I think Monica or Harry said earlier, is that when I explain that, I think sometimes people affected by cancer get a sense of, I'm talking about an elite athlete and they're doing a really high profile program, but it's not that at all. It's a very tailored, specific, targeted approach that's very suitable to meeting the person where they're at with their physical function, their capability and their capacity. So I really want to reduce the fear and the stigma around trying to get involved with exercise. It sounds sometimes frightening or overwhelming, but realistically, it's one of those things that it can really be delivered in a way that's kind of judged to be more of a targeted therapy or a medicine in the context of cancer in this space, and it ends up culminating in what Harry's trial has now definitively shown in likely disease-free survival, which we thought might be the case with epidemiological studies. And I'm so thrilled that it was a positive trial and that there was a really good outcome at the end of that trial, which will hopefully change the landscape, as Michael said before.
Dr. Michael Krasovitsky, I know you're dealing with geriatric oncology. I'm just thinking how you manage this in your world, because I've known people in palliative care who continue to exercise. It's very individual to the patient, isn't it? But how do you help those really older group who may be not frail but less robust to benefit from this exercise? Because it's about good quality of life for as long as we've got life, isn't it?
Absolutely correct. And I agree with all the comments said by my colleagues. I have a very standard one-liner that I say to all of my patients, which is the more energy you spend, the more energy you have. And I think that's just a really simple overview of the importance of exercise in keeping us robust and our energy levels up. I often tell people that the advice their mums gave them to convalesce when they're sick and tired is probably no offense to my own mother, not 100% correct. And it's actually on the days you feel worst after chemotherapy that you need to be exercising. It increases your blood flow. It is inherently a mindfulness activity, which we know can decrease your stress and anxiety. Exercise is much more important than many of the medicines Monica and I prescribe. If the medicines I'm giving to a woman after her breast cancer has been removed limit her ability to exercise, I'm much more likely to stop the medicine than I am to stop the exercise.
Fascinating. Carmela, could we have another question, please, from the audience?
Yes, I have another one. How do you get past the fear of cancer reoccurring?
Oh, Haryana, can you give us all dispensation? How do we?
Oh, look, I think we can't take the fear away because it's real. But I think the key message is that it shouldn't be intrusive. So it's about putting the fear in context and not allowing that to I guess, to dominate what your, the rest of your life. And so some of the strategies that we teach in our fear of cancer recurrence interventions are things like, I guess, training your attention away from the fear. So getting you to let it just kind of sit there, but not dominate, to not paying attention to the fear. Postponing worry. So a lot of people may feel that they need to worry about their cancer coming back all the time because that will help them to not worry or to stop the cancer reoccurring. And so I think we do teach some strategies that relate to setting aside a particular time of the day and for a particular amount of time to allow yourself to think about it and get all your worries out and then not think about it again. So they're the kinds of strategies that we talk about, some of the skills that are taught in that program that I mentioned, Conquer Fear. I think the other thing is that often it's about reevaluating what's important to you. So really reinforcing the things that really matter to you and living, is setting up the rest of your life in a way that allows you to focus on the things that are most important. So those core values about what gives you meaning in your life. And I think if we kind of come out of a cancer experience or a cancer diagnosis and treatment, sometimes we need to rethink about those things and refocus on them. And they may have changed as a consequence of having gone through that experience as well. But I do think things, as Nick said a few moments ago, things like exercise, really do help you with that mindfulness activity, a mindfulness approach. So it's very hard to focus on worrying about something else in your life when you're focused on staying upright while you're walking fast or running. I think that exercise has a role in helping us to stay mentally healthy as well. And I think part of this is also about recovering from an experience which is, for most people, taken them by surprise. Diagnosis often happens out of the blue, sometimes with symptoms, sometimes with not. And you develop an inherent distrust of what's happening in your body and the way that it's that it has not looked after you. And so there is this level of mistrust that needs to be addressed and sort of I guess, recovered from. So I think it's about reestablishing that level of of control or, being connected to your body in a way that means that you can live in it comfortably. And sometimes I think it's also, a lot of the things that we're talking about are really helping you to redevelop and reestablish that what we would call psychologically self-efficacy, so that you feel like you're capable of doing the things that you want to do. And that is really helpful. And I think, self-efficacy for lots of things is important, but particularly for exercise. And we know that flows on into other areas of people's lives as well.
I want to ask you just one more question. At the time we're speaking, we've just had across Australia the biggest morning tea with the cancer councils, and I went to one organised by a group of young cancer survivors in Adelaide, where I live. There would have been about 250 people in the room. Everybody was directly affected by cancer. The man I sat beside had survived 2 cancers. I'd survived another, and we didn't actually talk about cancer, but there was an amazing joy in the room. We'd all made cakes. We were chatting. Some people shared their stories. We raised $10,000, which in this community that I was in was a very large sum. And I suppose my question is this: in other self-help contexts, helping others, it can be a way of taking the focus off one's own trauma and getting some sort of relief and meaning from helping others. And I'm just aware in the Cancer Council world, there's a huge amount of volunteering by survivors of cancer. So I'll come to you, if I may, in a minute, Monica Tang, and get a comment. But is there any research on whether helping others deal with their cancer helps us to be free of the fear, or to at least diminish it and manage it?
I think there's not, as far as I'm aware, data about this, but I really, I do think that the sense of being able to contribute is very important to people, and so I think that that's really what it is. But I will say that being able to connect with other people and provide that sort of support or shared experience is also very important. So we mentioned earlier, Julie, the support groups and peer support as being important, and I think they are definitely ways for people to give back. And certainly in the study that we did, the challenge trial, and I know other studies that Nick and other people have been involved in, the relationships that develop in the gym or in walking groups and things like that can actually be really provide an informal support network with that shared experience, which is incredibly powerful in terms of helping people understand their experience and process it, but also to be providing support to each other.
Yeah,
I think that's really important.
Your observations, Dr. Tang, in terms of how people manage fear of recurrence.
Yeah, so as Professor Dhillon has said, it's really common. It affects, I think, most patients to some degree or other, and I think the vast majority of patients, for them, I think it's about normalizing the experience, explaining the trajectory, that it often seems to be most intense just after finishing treatment, because you come off, a very busy schedule of maybe coming to the hospital every day for 6 weeks for radiotherapy, and all of a sudden the doctors and the nurses say, see you in 6 weeks, and patients often feel a little bit adrift. So you'd let them know, look, it's normal to feel a bit anxious because there's now a new change to your routine, and it gets better over time. It'll be triggered by particular things like coming back for scans or appointments. There's some practical strategies to manage it. So a lot of the strategies that Professor Dhillon had mentioned, something that I say is, if you know that scans and appointments are really stressful, try not to have them spaced too far apart. I had a young patient who said, he thought because it fit in with his work schedule, he'd organize a scan 1 month and have the follow-up a month later with his oncologist, and he was just in pieces for that month, stressing about the results. So I said, look, if you can do it maybe 3 or 4 days apart, so there's enough time for the scan to be reported, but you're not ruminating about it for a whole month, taking support people with you for all of these appointments. They're really practical strategies, but I think that there is a subset of patients, as Harry's mentioned, where it does become intrusive. Patients are too scared to book a holiday next year. And I have a lot of patients who ask me indirectly about the prognosis, I'm planning to go on a holiday next year, or my daughter's graduating in 3 years, should I make plans for them? I say, yes, absolutely. You're very much likely to be cancer-free by then. But sometimes that level of reassurance isn't enough. And for patients who can't make plans for the future because they're so, affected by the fear of recurrence, and they do need that specialized support. And there's lots of great psychologists out there. There are programs like Conquer Fear, which I think is another homegrown intervention that's received a lot of attention internationally. There's another program called Cypher, which one of our colleagues from Michael's colleagues as well from the Kinghorn Centre is working on, which is about training oncologists to manage fear of cancer recurrence in the oncology clinic, rather than trying to access psychologists with oncology interests, which are quite rare and difficult to find. So there's lots of different ways to try and manage it.
Look, thank you. And I do want to do one more topic before we finish. We've got just over 10 minutes left, but I'd like to take another audience question, Carmela, if I may. Thank you.
Yes, well, one actually that came through from the audience was to comment on cortisol and cancer occurrence. That they believe stress leads to increase of cortisol, which compromises the immune system. Any comments?
Well, could I ask Dr. Monica Tang and perhaps Michael Krasovitsky as well to just see if they could each briefly comment on that? Thank you. Do you want to go first, Monica?
Yeah, look, I think that there probably is some evidence at a population level that high levels of cortisol and stress is not great for your health in all respects, not just cancer, but also, cardiovascular disease and things like that. So I think there probably is a link there, but I think a lot of patients sort of ask me or sort of tell me, oh, I think stress caused my cancer. I really need to stress less so that the cancer doesn't come back. I sort of tell patients that I don't think it's as black and white as to say that in a single patient that having high levels of stress will cause your cancer to come back. I tend to find that patients with that kind of frame of mind, it actually increases their stress. No one ever stopped stressing because you told them to, if a friend or family member is a bit worked up and stressed and you tell them, hey, don't stress, that's actually never helped. And so I think for patients to, live life with the aim of having no stress, I think that's very difficult to achieve in the 21st century. So I think, I guess we're all starting to sound like broken records tonight that, doing things that we know will help lower stress, lower cortisol levels, sleeping well, exercising, trying to eat a balanced diet. Those are the things that will make you feel better. They'll also probably lower your cortisol levels in the long run, and it'll be great for your overall health. But I think trying to draw a direct link between high cortisol levels and developing cancer or developing recurrence is perhaps not a very helpful or practical way to approach life.
Michael, if I think that question's been taken care of, could I take this opportunity to ask you about aggressive sleep management, which you say can be useful for some people? And I've just never heard that expression. So what is that, and when can it be helpful for people in the context of cancer survivorship?
That's a perfect time for Bogda to come in because I'm sure she's already laughing at my comment of aggressive sleep management. Look, sleep is such a fascinating component of life, truly inescapable. And I think as a society, we probably don't think about our sleep much unless it's not good. That's changing now that people have a variety of apps that they can use on their phone. But I don't think an app necessarily tells you how refreshed you are in the morning and how well you're functioning based on the amount of sleep that you've had. And though the term aggressive is perhaps a little aggressive for this term, I actually do think there's quite a skill to sleep.
And so what exactly do you mean? Just because we don't have much time, what exactly are you advocating as an approach? Because a lot of us have disrupted sleep during our cancer treatment and after.
Okay, so I'll be quick with my little list. So no caffeine after 1 o'clock in the afternoon, limited drinks with dinner, avoidance of alcohol at night, no screens for 1.5 hours before bed, turning the blue light on your phone so that you're getting an unfiltered light, which our brains are able to deal with more, making sure in winter that you use warm blankets or even weighted blankets, which can help the comfort of sleeping, making sure that your phone is in a separate room, changing your alarm sound. There's a lot to do. There's a lot to do to sleep well, but we actually can help sleep pretty well, I would say. I'm seeing some nods from my colleagues, but taking a proactive approach to sleep, we can get it better.
Yeah, and it's just obeying the list, isn't it? It's so desperately difficult. Monica Tang, if I could come to you, the one thing I wanted to mention before our time is up is metastatic survivorship. Can you explain what that means and what are the special issues for the person with metastatic cancer?
Yeah, as I mentioned earlier, the term survivorship is quite broad, so it does include patients who have metastatic, or what I call sometimes, treatable but not curable cancer. I guess from a personal experience, the Survivorship Centre at Prince of Wales Hospital, we've actually just started seeing patients with metastatic cancer in the centre with some parameters around, referral, and it's because the treatment for some cancers have become so good that that cancers, patients can live with metastatic cancer for many, many years. I've got patients who've had metastatic cancer for 10 or more years, and a lot of the issues they face are quite similar to patients who've just finished treatment for, early curable cancers. And so a lot of the things we've spoken about exercise, about diet, about sleep, about sexual function applies to them just as much as to patients who've, completed treatment for early cancer. And I know we're running out of time, but I know Nick also has a special interest in this area as well.
Let's all hold hands and agree to call it lovemaking, not sexual function. Just say to your partner, let's have some sexual function tonight. Hey, let's go for it. Let's function.
Well, at least that has fun in it.
Yeah, that's true. You can put the fun into function.
But Carmela, could I have one more question from you? Have we got any more topics just before we finish up?
Yes, there's actually quite a few, but I think this one is quite important for the people listening. I think it has been mentioned, but it would be nice to just hone in on it. It says, where are people affected with cancer able to access well-being support and guidance after cancer diagnosis? So I know there is the Prince of Wales, but if you're not part of that, where can you access it?
And I'm going to bring on a new special guest to answer that question. And it's very exciting that Professor Bogda Kochvara has been able to join us, a medical oncologist, a clinical researcher. And in April this year, 2025, Bogda was appointed as the inaugural director of the Australian Research Centre for Cancer Survivorship, our topic tonight, jointly funded by the University of New South Wales and Cancer Council New South Wales, and $40 million involved. Bogda, welcome. For those watching and listening and watching later, she's been caught up in great storms across Australia and is arriving late, but it's so wonderful. If I could welcome you to the screen, Bogda, and where can people access these services? We've been talking about both specialist services, but also mainstream cancer teams, but where can we get people with specialist services, I think was the question.
Sure. Thank you, Julie, and apologies that I couldn't join you earlier. Look, it's a complex issue to answer because at the moment in Australia, the services for cancer survivors are fragmented and limited. And the challenge that I see for us collectively in terms of developing services, and the challenge that I hope that the research center will try to address, is how can we develop appropriate services for cancer survivors and at the same time manage the demand? Because the good news is that we have a lot of cancer survivors in Australia. There is probably about 1.4 million around Australia, and there's probably about 500,000 in New South Wales alone. So if you were to do your maths and suddenly say we're going to have a clinic for every single one of them, it's just not going to be terribly realistic because all our resources would be consumed by delivering services one-on-one. So we have to be smart in it. And what that means is, first of all, we need to identify individuals who need services and what services they might need. Different people need different help. Some need psychological support, some need exercise, some need financial support, and some say, I'm perfectly fine and I don't need anything. So I think we need to have a sensible way of finding out who needs what. And the second thing is we need to deliver the type of support and the complexity of support according to the complexity of need. So some ideas of how to go about it are as follows. The Cancer Institute New South Wales is growing a program of electronic collection of information regarding patients' needs. So ideally, you should be able to be sent a text message saying, can you complete this series of questions to identify what might be particular needs that you have. Now, that's currently probably covers about 1 in 5 patients in acute treatment in New South Wales. Ideally, it should cover all of them, and it should extend to people who are cancer survivors who have completed treatment and might be seeing their GPs, for example. So that's one way of finding out who needs what. The second thing is we need to recognize that services could be delivered in a number of places. ranging from something that is relatively simple, like connecting to existing community support groups, usual, let's say for physical activity, connecting to community interventions, reaching out to your GPs for support, to going to more complex needs for those who have more complicated requirements, where we need to create facilities that actually provide services, and they might be for a variety of problems, whether they are heart problems or joint pains or mobility problems or fatigue or deconditioning where exercise is needed. And for majority of survivors, those sort of interventions might be required for a short period of time. But there will be a small proportion of survivors who would have really complex needs, and those probably require complex and long-term input. So I think the challenge for us is, how do we balance limited resources in such a way that we get the right intervention to people who need them, and we do not overburden those who don't need them or don't want them? And to do that, we need to start thinking about how we deliver care a little bit differently, using technology, using computers, reaching out to people so they can have ability and support to identify their own needs. All this can be done, but at the moment, it requires quite a lot of refinement before we can say that we're right on target.
Unfortunately, time is almost up, Bogda, but I want to ask you this. We talked earlier about the role of the general practitioner and also navigation, service navigation support. Just in a nutshell, what sort of work are you hoping to do at this new national centre in terms of the role of the general practitioner? And what strikes me is, at the moment, there's a relatively low awareness about even the term cancer survivorship, or the fact that some cancer survivors need very long-term support. And I'm obviously thinking of my peer head and neck cancer people in that regard. So where's the GP in all this?
Look, I actually think the GP is critical, because one of the when we think about what are the problems that cancer survivors would encounter, many of them are not cancers. It is not, of course, there is a risk of cancer recurrence, but for survivors treated with curative intent, one of the biggest problems long-term is cardiovascular disease, and very often deconditioning, fatigue, peripheral neuropathy. These are not problems that oncologists are very good at managing. GPs are actually better at managing them. So GPs are critical. I want to jump in, because I am mindful of the time. I really want to flag the issue of navigation. And in addition to professional navigation that Cancer Australia is rolling out, there is tremendous potential for peer navigation, community navigation, and sort of lay navigation that has been very successful outside of cancer. And we can really bring it into the cancer sphere, where we can really capitalize on the skills and expertise of people who might have been there before and who are happy to contribute their expertise. So there's much that we could do. And I think that Centre could potentially really develop some of those approaches and raise awareness of who survivors are and what can be done.
I'm so pleased you made it, Bogda. I'm seriously pleased, and I really thank you for the effort. I don't know. So I want to thank all our panelists. You've just been marvelous this evening, and I especially thank our special guest, Professor Bogda Kochvara, and just a reminder that there's this new Australian Research Centre for Cancer Survivorship. She's the inaugural director. But thank you to all our panel members.